Hello and welcome to lecture 11 of the Principles of Exercise Therapy, PET, for undergraduate physiotherapy. This lecture is about exercise instruction and feedback. As you can see, it's a two-way process. You give a message, but you also need feedback, and it's this feedback loop that is important. Communication is the key here. So what's our profession about? Okay, this is our mission statement. We need to get this very clear in our minds. It's about anatomy and physiology, human movement and function, maximizing wellness and potential, minimizing disease and injury, and solving real-world problems. Our mission statement is important because it helps us focus on prescribing exercise. So with exercise instruction, we want you to practice using motivational interviewing, MI, and we'll come on to that in a minute. Practice using the ABCDs of lifestyle counselling. Reflect on the different types of learning styles that we have. Consider how you can teach new motor skills and new exercises effectively. Consider the factors which influence adherence. Adherence to exercise is the most important thing. And practice teaching exercise, correcting performance, and providing feedback. So we've got a sport billy, which is the principles of exercise therapy. We've got adaptation, specificity, progression, regression, overload, reversibility, timeout, behavioral change, individuality, lifestyle integration, law of diminishing returns, and your responsibility. And you remember that with the acronym ASPORT BILLY. Right, we've got to make every contact count. Our friends at Exercise Works, Anne Gates, has really been a champion for this point of making every contact count and advising on physical activity and exercise whenever we get the chance to. Just think of how many patients we can influence over our career. So we've got this short amount of time with the service user, and we've got to make an impact with regard to adherence and behavioural change. Unless we change behaviour, nothing changes. We're using evidence-based techniques. Okay, motivational interviewing is not telling the patient what to do. It's listening to the patient and suggesting so that the answer comes from them, working in partnership with the patient and avoiding the waggly finger of I'm the clinician, so I know best. So in order to remember how we structure motivational interviewing, as I put my teeth back in there, we use the acronym OARS. So we use open questions. Yeah, avoid yes, no, closed questions. Affirmations, reflections, and summaries. Okay, so let's study these in a bit more detail. So, how do you feel about your exercises? Is a chance for the patient to talk about their feelings and their thoughts around the exercises. Are you doing your exercises? Okay, is what's on the physiotherapist's mind. So you can see the difference between being patient-centered and being physiotherapy-centered. Okay, and it's all about patients, patient-centered care. Affirmations. These build the self-confidence of the patient. So the patient says, I haven't done my exercises, or I only did the exercises once. You've got to reward them for at least having an attempt, having a go at doing their exercises. And then picturing in life where they have achieved things before and accomplished things before, and using that success momentum so that they can use the strategies that they've had success with regard to exercise. Success breeds success. Reflections, what the patient is thinking and feeling. So repeat this back to the patient. So let me get this clear. You're having an issue with time, and that's why you're not able to do your exercises. Yeah. Try and use reflective statements, not questions, and see the world through the patient's eyes. This is really effective if we get it right. Summaries. These are long reflective collections of all the patient's statements. So it starts with this. If I understand you correctly, you want to do your exercises, but you're unable to do them because of time and busyness. So you have the inclination, you know they will do you good, but it's really a prioritization and time factor. Is that correct? So you're selectively summarizing to help with behavioral change. This way the patient knows that they've been listened to and they know that they've been understood, and you've built rapport. So then we move on to the ABCDs of lifestyle counselling. And this is only a paper that was a couple of years ago. So we've got to assess the patient. We've got to see the barriers. We've got to get them to commit. And then we've got to get them to demonstrate. So assessment. So are you concerned about the effect lack of exercise is having on your health? Is a fair question. Do you believe you need to make a change to the physical activity that you do? On a scale of 1 to 10, how important is it for you to change your physical activity levels? And on a scale of 1 to 10, how confident are you in your ability to change your physical activity? These are good questions that will make the patient think. So the barriers. So what do you believe are the barriers to making a change in your lifestyle? Time, money, motivation, not understanding, lack of motivation, lack of inspiration. These are all barriers, and it's about trying to dilute those and understand them so that you can counter them and conquer those barriers. Commitment. What would it take for you to overcome the barriers to that lifestyle change that you mentioned? Giving the patient back the responsibility. You want to overcome these barriers. How are you going to do it? And then get them to plan. Okay, what plan makes sense to help you with your lifestyle change? Working with them, nudging them, coaxing them, rather than waggling the finger. I'm the great clinician, I know best, because that will only make the patient not adhere. And then demonstrate. How do you suggest we monitor your progress regarding your lifestyle change? So it might be on some sort of monitoring system like a Fitbit, or on your smartphone, or any sort of mobile application device where you can track your exercise habits. This is a good way of demonstrating and building data. Anything that gets measured gets managed. So now we're going to move on to learning styles. So we've got to adapt our learning style according to the patient's preferred language. So that if they say things, I see what you mean, yeah, I can visualize that. That is a very visual system that they're using. Or if the patient says, yeah, I hear what you're saying, okay, it's not clear to me what you're saying, okay, that's auditory. Or, yeah, I feel what you mean there, okay, yeah, that's, I can literally, I can get a handle on what you're saying. They're using kinesthetic language, or they might be using analytical language, okay, and the analytical language is for someone with a more developed sense of their learning style, who might use a combination of all three. So, like it or not, you're going to have to be a teacher. And this is important, because effective exercise instruction is an essential element of exercise therapy. So, your patients and your clients must be able and motivated to carry out the prescribed exercises independently, i.e. without you. So, motor learning. So, it's a complex set of internal processes that involve the relatively permanent acquisition and retention of a skilled movement or task through practice. Knapp defines skill as the learned ability to bring about predetermined results with maximum certainty, often with minimum outlay of time or energy or both. So 3 stages of motor learning. The first is the cognitive stage, where you're trying to understand what you've got to do. You're consciously thinking about it, you're going to make loads of errors, and you need constant correction and feedback, that early stage learning. Then you're in the associative stage, where you focus on fine-tuning, and you can explore some variations, you can do a bit of problem solving, and you can self-correct because you understand what's going on. You can anticipate errors, and you require less feedback as you're becoming more skillful. Then in the third stage, okay, it's autonomous. It's automatic movement. You don't have to pay attention. In fact, you can do other tasks while you're still doing the same task. And you can adapt easily to variation, and you require very little instructional feedback because you know exactly what you're doing. So the factors influencing motor learning, we think about pre-task. So before the person does the task, do they understand the purpose? Back to functional movement. Okay, what are the person's interests? What's their attention and their focus? Remember, where focus goes, energy flows. Understanding the desired outcome, what you want to achieve. Demonstration or modelling might be required, and the quality of your instruction is oh so important. Then, during the practice, it's about repetition. Okay, 10,000 hours or 10 years of repeating the same task means you'll become a master in that task. Okay, and you can do part practice and then whole practice. So you break down the task into simplistic bits. Say, for instance, a tennis serve. Okay, you could practice just throwing the ball up in the air. So get throwing the ball up in the air. Then you could practice raising the racket, leaning back. Okay, and then you can actually practice just hitting the ball. And then you put it all together. Yeah, so there's lots of ways of doing it, including things like visualization and doing the tennis serve without the ball, etc., etc. So the factors influencing motor learning might be feedback. So that might be from videoing it and then showing the patient what they're doing wrong, or it might be from sensory information such as intrinsic feedback. Can you feel that via proprioception, or external feedback where you might be using hands-on to adjust the patient. So the important factors to consider are your environment, then your demonstration. Are you correct? Are you safe? They've also got to know what incorrect technique looks like so that they don't do it. You've got to physically guide and facilitate them, and you've got to give clear and concise instruction. This could be verbal, could be written, could be video. Okay? You've got to give the patient a playback. So this is where it's good, video it on their phone and then show them what they're doing. And the feedback must be specific to that task. It also must be incremental or phased in the instruction. You can't just give somebody 10 points and they'll only remember 1. Okay? And the other one is that you've got to give them a reward, whether that's verbal, okay, or a finger of fudge, okay, that David Dean likes to do. And they've got to enjoy the task. That's the important thing. So your instruction, you've got to have a clear plan of what you need to say. You've got to build that collaborative relationship, building rapport. You've got to negotiate the goals. What does the patient want? And you've got to coax them into what they need. You've got to consider learning styles, visual, auditory, kinesthetic, analytical. You've got to also look at the patient's belief system. Okay, what do they believe about? If they believe exercise is painful, they're not going to do it because you want to avoid pain. And we've got to ensure that they achieve early success, because success breeds success. So factors influencing adherence are many. So there are patient-related, disease-related, and treatment-related. Okay, all of these will factor. Adherence, it starts from a position where you expect the patient not to do your program at all, rather than expecting they will. So giving the best program in the world to a patient that doesn't do it is worthless. So it's vital that you understand adherence. It's more important than anything else. And you could, for instance, increase somebody's activity by hiding the TV remote. Okay, that's particularly good. I like that one. Well done, Linda. And so if we follow it up, what should you have learnt by the end of this session? You should have learnt about motivational interviewing, using your oars. You should also know about the ABCDs of lifestyle counselling. We've got to think about the different types of learning style that we have, and we've got to think about how we teach new motor skills and exercises effectively. We've got to consider adherence as probably the most important thing that we do, and we've got to practice teaching, correcting, and giving feedback to our patients. Thanks for listening. Hope you enjoyed that, and we'll see you in the next podcast.